Hello everyone, welcome back. My name is Dr. Sonam Kivarkar and welcome to Spondyloarthritis Part 3. So this was your pre-work. I really hope you've got a chance to listen to these excellent podcasts. If not, now it's the time. Scan the QR codes and learn more. Let's jump to the objective of this slide set. Discuss definition, clinical features, investigations, and management strategies for psoriatic arthritis. Just to refresh our memories, psoriatic arthritis falls under the umbrella of spondyloarthritis. It is mainly a peripheral arthritis, so it is arthritis associated with skin psoriasis. This arthritis is the term arthritis is given because it is an inflammatory arthritis. That means a person will have inflammation in their joints. So there is swelling, there could be redness, there is warmth if you touch the joint, so on and so forth. The psoriatic arthritis can be pretty destructive or erosive or deforming in the later stages. The prevalence of psoriatic arthritis is about 1 to 2%. I beg your pardon, it's 1 to 2 per 1,000 in the general population. And if you take all the people who have skin psoriasis, then about, I would say, 20 to 25% of people with skin psoriasis have psoriatic arthritis, and the sex prevalence is almost 1 to 1%. So psoriatic arthritis comes in many flavors, okay? So you could get asymmetrical oligoarthritis. That means maybe one knee and maybe a few joints of the hands could be involved. So it is asymmetric, okay? And it is oligoarticular. That means either 2, 3 or 4 joints are involved. If it is monoarthritis, it is one joint involved. If it is polyarthritis, 5 or more joints involved. So anything in between is oligoarthritis. So one of the features on how psoriatic arthritis could present, it could present as asymptomatic oligoarthritis. Another way it could just present like rheumatoid arthritis, it could be polyarthritis and symmetrical. It could be purely enthesitis related. So to just refresh our memories, enthesis is the point on the bone where the tendon attaches to it. So in this diagram, this is the Achilles tendon and it attaches to the calcaneum bone right over here. So inflammation and pain on this part is enthesitis related arthritis, which could also be one of the presenting features of psoriatic arthritis. Psoriatic arthritis has a mind of its own. It could just attack any of the joints. One important thing to remember is distal phalangeal joint involvement. That is the DIPs. So these knuckles get involved, which is actually not seen in rheumatoid arthritis. Rheumatoid arthritis spares the distal interphalangeal joints. Further, psoriatic arthritis could cause destruction and erosion and could lead to this telescoping of the joint that you see over here. That means the bone is destructed and you just have loose skin on top of the bone, which can slide like a telescope. Sounds pretty yucky, but that's how deforming is the arthritis. And then you could also have sacroiliitis, that is inflammation in the sacroiliac joints. So remember, psoriatic arthritis is mainly peripheral. So remember your basket, remember Farrer's market. If it is psoriatic arthritis, you need to have skin psoriasis and arthritis. Arthritis can be peripheral mostly. Rarely it could be axial. So these are the criteria for diagnosing psoriatic arthritis. These are known as Casper criteria. And you must have at least 3 or more than 3 points in the following categories to diagnose somebody as psoriatic arthritis. So either they need to have a history of psoriasis, or have a family history of skin psoriasis. They need to have these typical nail lesions. So skin psoriasis also affects the nails, which could give rise to pitting of the nails or flakiness of the nails, just shown like over here. They need to have the rheumatoid factor negativity, and they need to have dactylitis or some changes on the x-rays as seen in this panel. So if you earn 3 or more points, you get diagnosed with psoriatic arthritis. So remember, psoriatic arthritis falls under the umbrella of spondyloarthritis. It's mainly a peripheral arthritis. It is associated with skin psoriasis and nail psoriasis. It's mainly peripheral arthritis, okay? And when I say arthritis, it is not just pain, but there is inflammation in the joints. Okay, so let's talk about the investigations for psoriatic arthritis. So of course, history is very important, and especially the family history is important in psoriatic arthritis. You can get a complete blood count and a complete metabolic panel. You can also get inflammatory markers like ESR and CRP that could be elevated in this condition. If there is a swollen knee and you decide to aspirate the synovial fluid, then typically this fluid will be inflammatory in nature, meaning that there will be more than 2000 cells, WBCs seen in this fluid, and it will be negative for any infections. And you can also get x-rays done, and in late osteoarthritis, in late stage psoriatic arthritis, you will have changes as seen on the previous slide. Okay, now let's talk about the treatments of psoriatic arthritis. So we first start with NSAIDs, that is non-steroidal anti-inflammatory agents like naproxen, meloxicam, Aleve, ibuprofen, so on and so forth. If that doesn't work, then you could try these disease-modifying rheumatic agents, also called as DMARDs. You can do sulfasalazine, methotrexate, leflunomide. If that doesn't work, then you have so many agents like TNF inhibitors, like adalimumab or infliximab, these tongue twisters, right? But you might have listened to one of the TV commercials or radio commercials for Humira. Or Enbrel and or Cosentex, right? There are just so many biologics available in the market, so many new medications coming up every year for psoriatic arthritis. I think people with psoriatic arthritis do much better than they used to do because of the availability of such a plethora of medications. So that's psoriatic arthritis in a nutshell for you guys. Again, don't hesitate to ask questions, follow this link or QR code, and post your questions on the Arthritis WSU WhatsApp group, and I'll be sure to answer your questions within 24 hours. So see you until the next lecture.